Welcome friends. Today we will discuss mini open TLIF, which is an interbody fusion technique for lumbar spine. Any technique which we like to use should be easier to learn and should be easier to perform as well. Ideally, it should not increase the cost of the surgery, and we should be able to do it anywhere with minimum armamentarium requirement. Surgery ideally should be fast and should be safe for the patient as well as to the surgeon. And if possible, especially for the spine surgery, it should follow the principle of MIS surgery. MIS TLIF is a well accepted technique for lumbar interbody fusion. It provides all benefits of an MIS surgery, which are small skin incision, minimum blood loss, less pain medicine requirement with early discharge and quicker recovery. Conventionally, MIS TLIF is done wherein the interbody fusion part is done through a tube or expandable retractor, and the pedicle screws are passed in a percutaneous fashion through multiple stab incisions. These screws are passed with the help of the fluoroscope or navigation. There are several drawbacks of this conventional MIS technique. The technique is heavily dependent on the SIAM, which leads to a lot of radiation hazard. Screw breaches are not identified. We need a very good SIAM and OT table. So it is not possible to do this kind of surgery at every place. Navigation wherever available can be utilized to avoid the radiation. However, the patient is still subjected to radiation to capture the navigation data. The cost of navigation or OAM is very high, and it is not feasible to have these equipments at all the hospitals. In contrast, mini open TLIF provides all the benefits of an MIS spine surgery without the hazards of conventional MIS TLIF. In this procedure, TLIF is done through the expandable retractors, and the screws are also passed through the window between the retractor blades using the anatomical landmarks as it is done in an open surgery. The same procedure is repeated on the opposite side also, and the screws are passed without heavy dependency on the SIAM. Steps of this procedure is ipsilateral retractor docking, followed by the TLIF procedure after doing the facetectomy. Ipsilateral and, if required, the over-the-top contralateral decompression. After that, ipsilateral screw and rod, followed by compression between the screws to catch the cage in position. Contralateral retractor docking, and in cases of non-lytic fusion, a facet fusion can also be attempted on the contralateral side, because we are able to see the facet joints through that mini open incision. Followed by contralateral screw, rod, and if required, you can compress on the other side as well. A 3 cm long incision is taken about 3 to 4 cm paramedian to the midline. Initial needle is passed and the level of incision is determined as is seen in this X-ray image. After the skin incision, dilators are passed, and on these dilators then you confirm the position of the dilator on the right facet, correct facet, as is seen in this particular SIAM X-ray, where the dilator is targeting the L4-5 facet, because our target is to do L4-5 fusion. On top of these dilators, the expandable retractor system, which is called quadrant, is passed. After the quadrant retractor placement, you can confirm the level of your fusion before you make any final bony cut. The TLIF is done in a conventional method through this mini open incision, wherein the upper facet, the inferior facet of the upper vertebra is cut in horizontal followed by in a vertical fashion, and the overhanging part of the superior facet of the lower vertebra is cut. So we gain access to the disc under concern. Through this disc, we do the interbody fusion by inserting the bone graft as well as cage. Screws are passed using the conventional anatomical landmark. So typically, if you see the spine in a lateral, in a dorsal view, so intra-op through this mini open incision technique, you see only this much area, and you utilize these conventional entry point. So this is what we see during the surgery. We can see that the facet joint is there. I'll show this again. So there is a facet joint, pars lateral border is seen, and the entry point for the pedicle screws are also seen. This retractor has the ability to expand. Here we are seeing it in the closed way, but you can expand this retractor as well as you can angulate it, as is seen like over here. So it gives you enough access inside to perform your procedure, and this leads to availability of the conventional anatomical landmark for screw insertion as well after you have done TLIF component of the surgery. Once the cage is placed, you pass the screws. In the beginning, you can take multiple shoots to confirm the screw trajectory, as is done over here. So after the screw insertion, the rod can be put, and then contralateral screws can be inserted, which are seen over here. Because of the overlap of the screw with the opposite side inserter, the starter, we are not able to see the entry point on the contralateral side, but it is denoted by this red line. This is the picture after the contralateral screws have been placed, and the rod is also applied on the opposite side. So this is the final lateral shoot, and then this is the final AP shoot. You can see in this red circle that total 9 C-arm shoots are required, which are similar to an open surgery. However, here we are able to achieve full benefits of an MIS surgery as well. And that's a typical incision about 3 cm long on each side to the patient's midline. In our view, there are several advantages of this procedure. It's an easy and straightforward technique which is more familiar to the surgeon. There is minimum radiation hazard. We have done 2 levels fixations also utilizing this technique, and few 3 levels also. So for a single level 6 to 9 shoots, nowadays we are able to do it in 5 to 6 shoots most of the time. For a 2 level, about 10 shoots are required. Screw position is better because we are able to feel the screw trajectory. We can use any screws. We don't have to use the percutaneous cannulated screw. Maybe these non-cannulated screws are sturdier also as compared to the cannulated screw. There is less facet violation because as compared to percute screw, here we are able to see the facet joint and the exact screw insertion point. It can be done with minimum armamentarium. The only additional thing you will need is that expandable retractor. And probably rather than having multiple stab incision, it's cosmetically it is more desirable to have 2 1-inch long incisions. You can also attempt contralateral facet joint fusion through the contralateral mini open incision, and this might provide additional layer of stability to the entire construct. So putting it to our previous criteria, so is it an easy to learn technique? Yes. Easy to perform? Yes. Not costly? Definitely. We need minimum armamentarium for this procedure? Yes. It's a fast procedure and safe because we don't utilize much of the radiation intra-op, and it does give all the advantages of MIS surgery. Most of the patients are able to go home very next day or maybe post-op day too. You can face some technical problems, and mainly it's a wrong docking or inadequate decompression, like which is like specific to any mini or MIS TLIF. Sometimes it's difficult to put a cage of size which is more than size 14, and for a heavy set patient the depth might pose some issues while you are inserting your blade and trying to do a TLIF or screw insertion. So in these situations you have to you have to keep the longer blades of the retractor system available. Screw insertion specific. If our docking is wrong, if we are too medial, then the decompression will be good, but the screw trajectory will not be good. If the docking is too lateral, then the screw trajectory will be good. However, the decompression, especially the contralateral decompression, will be difficult. Rod insertion can itself pose some problem to the beginners, and screw compression can be difficult, but we have come out with some ideas how to achieve the screw compression across the cage, and we will show it. Ideal docking should be right at the facet joint with little medial inclination, so you can do decompression as well as you can pass the pedicle screw also. However, if your docking is too medial, in that case your decompression will be okay. However, screw insertion will be difficult. In contrast, if your docking is too lateral, then your screw insertion will be easy. However, your decompression will be difficult. You might be able to achieve one-sided decompression at best, but for the contralateral decompression, then you might have to either do the same procedure on the contralateral side or put a tube inside this system and tilt it medially. One of the drawbacks of this system is that it is difficult to tilt this blade system too far medially, because the muscles will creep in the retractor blade, and the retractor blade can get detached from the actual retractor system if you manipulate too much. So one of the solutions is that before you start your incision, you can take an AP shoot and plan your incision accordingly, so that you are not too medial or too lateral. Rod insertion can pose some problem, that how to put a rod through this small hole, but most of the time we are able to do it without significant difficulty. So the rod goes in vertical, and as it goes in you can keep on tilting it, and then finally it will sit in the tulips of both the screw heads. For screw compression, there is a technique wherein you pass a compression system on one of the tulip wherein the innie is tight, and you pass your counter torque with the screwdriver in it on the side where the innie is loose, and you can compress it across as a lever and then tighten the screw in the counter torque. If the compression system is not available, then we have come out with a simpler technique also, wherein we tighten one of the innie, and on the loose innie side we pass the counter torque, and through which we'll pass a screwdriver, and we'll put a cylindrical thing between these two screwdrivers, like a handle of a cob elevator, and you can press then in the part of the screwdriver which is next to the skin here. So once you do that, it will compress like this, and then you can tighten your innie in the tulip of the screw. Sometimes soft tissue can creep in. For that, a mediolateral retractor is available with this expandable retractor blade, and that can be utilized. If you are doing a two-level mini open TLIF, it can sometimes struggle, because that adjusting the retractor blade to pass two-level screws can be slightly difficult. There are some limitations of this procedure as well. It definitely has a learning curve. As we spoke, rod insertion can be a little tricky in the beginning. It requires one big investment of that minimally invasive retractor with the retractor blade, and it is suitable only for 1 to 2 level fusion only. Percutaneous screws we are not totally eliminating. They have their own advantages, especially for the trauma or tumor patients. Some people do MIS TLIF also with the ipsilateral screws being put through the quadrant blade, and on the contralateral side they put the percute screw with the stab incision. So that's a sort of hybrid technique. And last but not the least, this technique doesn't look very glamorous, because you are passing the routine screws. There is no fun, but it does definitely give all the advantages of MIS TLIF without significantly increasing the cost of the surgery. Now let's have a look at the surgical video. So our needle is in place to assess the site of the incision. We take one X-ray. The target is L4-5 here, the needle is at around L5 pedicle, so the incision will be slightly above the needle placement. The incision is about 3 cm long, about 3 to 4 cm on the left side of the midline. This is a case of L4 lytic listhesis. The patient's primary symptoms are on the right side. We are targeting the left side first. By inserting the finger inside the fascia, we feel for the L4-5 facet and we pass our dilators one on top of each other inside. You do a little bit of bending so that the muscles are removed from the placement of the retractor. Once the retractors are in, you can take one X-ray to ensure that the dilators are in place. On top of these dilators, our expandable retractor will go in, which is attached to the table side with the help of a rigid arm. You open up the retractor system and start removing a little bit of muscle tissue which will come inside your vision. If you are not too sure about the placement of your retractor, then you avoid damaging the facet capsule until you confirm the level, like which we have done over here. Once we confirm the level, then we can damage the facet capsule because we have to do facetectomy over here. You can angulate the blades of the retractor to create more space, to create the more working space inside. Now this is a case of L4 lytic listhesis, and you can see the moving L4 lamina. Now the patient's symptoms are more on the right side, but we are removing the facet on the left side first because we will use this facet and the bone which comes out for the fusion, because majority of the time we get little less bone for fusion. You remove the facet with the help of a osteotome after removing the pars. Once you remove the inferior facet of L4, you can see the superior articular facet of the L5 facing at you. You do have to remove a little bit more of bone of the L5 overhanging facet so that the disc space gets revealed. Now in this case, patient did not have significant left side symptoms, so we are removing the L5 facet just to correct the extra bone graft. So you remove the overhanging part of the proximal part of the facet of L5. You also go medially and remove the medial overhang of the L5 facet. This will free up the L5 nerve root on the left side, which is a traversing nerve root going medial to the L5 facet for L4-5 joint. We put our round tip probe inside the ligamentum flavum to create our space and then remove a little bit more of ligamentum flavum if required. Now after this step, we do expose our bony entry points for the pedicle screws, and these entry points are same as we do for open surgery. So after creating the raw surface at the junction of the transfer process and the facet joint, you make your you put your starter and create the hole. At this stage, if you want, you can take some lateral x-rays to confirm the position of the and the direction of your instruments. In these holes which are created, then with the help of a lanky probe, you will create your pedicle insertion track. So lanky probe, depending upon the angulation which you get, you can put it facing laterally or maybe you can put it facing medially. The medial-lateral direction is more by feel and experience. Supra-inferior direction we check on the lateral shoot of the C-arm so that our screws are going in the right trajectory. After the lanky probe, you feel from inside. So you confirm your screw track. You tap the area for the screw track and reconfirm the pedicle trajectory. When you are sure that your pedicle track is made nicely, then you can insert your screw. So sometimes we face some difficulty in passing these screws because the retractor blades, they come in the view. So in these kind of situation, you can loosen the proximal part of the retractor handle and can readjust the retractor blade. So here we have already inserted L5 screw. Now L4 screw is going in. So again, with the help of the lanky probe, you will create your screw track. Once the screw track is created, you feel that you are within the confines of the bone. And once you ensure that, then you can tap, and after the tap, you again reconfirm that your screw track is good, and when you are sure about that, you can pass your screw. Again, that's the beauty of this technique, that the screw insertion is similar to the open technique, which most of us are familiar. Plus, you are able to feel the screw track. You are not putting it under the CM guidance. So, you are not putting it under the CM guidance only. The screws being misplaced, the chances are next to nil. Once both the screws are in, you align the tulips of the screw head, and then you can insert your rod over here. Insertion of the rod can be tricky, especially if you are doing a 2-level. However, for single level, we never had any difficulty. At most, you pass the rod little vertical as we are doing over here. But as you go down, the space is more because we have angled the blade for the retractor. So once you go deep in, you get better length. You position the rod in the screw tulip and insert the innis. At this stage, we are not going to tighten the innis because we are going to go on the contralateral side. The side, in this particular case, the side which is more symptomatic. So that side you will be doing the decompression and the TLIF. And when you are doing the TLIF on the other side, we want these screws to be, the rod to be flexible attached, so we can have some opening of the disc space for the insertion of the cage. So once we put the rod loosely inside, we come out, then we go on the other side of the patient. Now we are on the right side of the patient's body. Again, an incision of about 3 cm length is taken in parallel to the contralateral incision. Here we don't have to take another CM shoot with the needle in, because we already know that we are at the correct level. So we can take another incision right in the line of the other incision. You go deep down to the fascia, cut the fascia, feel for L4-5 facet as well as L3-4 facet, because near to the L3-4 facet, our L4 pedicle screw entry will be there. With the dilators, you target the L4-5 facet joint, because we have to do the facetectomy of the L4-5 facet joint. From there, you will get the entry for the L4-5 disc. Dilators will go. You do a little bit of bending to release the muscles for your to create some working space inside. On top of the dilators, the retractor goes in, and this retractor then gets attached to the rigid arm to the table side. Little bit of cleaning of the muscles is mostly required to expose your pars interarticularis of L4 and the facet joint. Here we are trying to expose the L4 entry point just lateral to the L3-4 facet joint. You start removing the pars from the lateral. You can see that the lateral inferior facet of the L4 is moving freely because of the L4 pars interarticularis fracture. You remove the parts horizontally, and you also remove as much as of the bone which comes out with it. All this bone will be utilized later on for the bone grafting, for the interbody fusion. Part of the lamina can also be removed. Now similar to the other side, on this side also we have to remove the medial overhang as well as proximal overhang of the L5 superior facet, and more so on this side, because this side we need to ensure that we are doing thorough decompression, because this particular patient symptomatology was on the right side only. So we had to see the L5 traversing route for sure. If on the pre-op MRI there is foraminal stenosis, then you can have a look at the L4 exiting nerve route also. Some amount of bipolar cautery is required to be worked up over here, because as soon as you enter in this area you will find some bleeding bone. Again we are taking out the L4 inferior facet joint, and will be utilizing this bone for the interbody bone grafting. Now that the medial overhang of the L5 superior articular process, once you remove that, the traversing route which is running medial to this in the lateral recess, that is the L5 nerve root, will be freed, and that you are confirming right now. Also you need to release the ligamentum flavum in this area, because once you remove that you will start seeing the L45 annulus, and that will be your entry point for the discectomy. Here you can see that the L5 nerve root is being probed, and it is ensured that it's running freely in its course. Ligamentum flavum excision is required to expose the L45 disc and the annulus properly. You pass the patties on the shoulder of the L5 nerve root to push it away from your working zone. Also it will prevent any bleeding which is coming from that area. We can see the yellowish white annulus of the L45 disc. Another patty is passed in the axilla of the L4 nerve root. Annulus is excised with the help of a 15 number knife. Now the aim will be to remove as much as of the disc from the interbody area of L45, prepare the end plates, and insert the bone graft and insert the cage for the fusion purposes. So initially you remove some part of the disc with the help of a pituitary ronger or the disc forceps. Once you've done that, you pass a smaller size of shaver to remove the bulk of the discs, bulk of the disc material, to free up the space for the insertion of the graft as well as the interbody cage. So in the beginning you will pass a shorter size of the shaver, but once you create space inside, you pass a bigger size of the shaver. When you start getting a tight feel while rotating the shaver, so that will decide that approximately what size of the cage will be going in. Now these shavers will free up a lot of disc material which you remove. We use this custom made device which has a lot of teeth to prepare for the end plate. So we go in and we remove the cartilaginous part of the end plate, both on the lower side, which is the L5 upper end plate, and the upper side, which is the L4 lower end plate. At this step you need to be careful that you don't cave in to the bony end plate, otherwise your graft as well as cage might sink inside the body of the vertebra where you have violated the bony end plate. Now here we are checking the final size of the cage. Once we have removed enough bone and enough disc from inside the interbody area, we pass this funnel instrument, and the prepared bone graft, the small pieces, now will go in. It's very important that you put very little of the bone graft in one go, because if you put too much, then it might get stuck, and you may not be able to push it inside the interbody disc area. So little bit of the bone graft multiple times will do the trick. Once you are happy with the amount of the bone graft you have put inside, now in case you feel that the bone graft is less, you can use with a small incision, you can remove the iliac crest bone graft, or you can use some bone graft extenders like beta TCP, which may be mixed up with the bone marrow aspirate. We are putting a scissors to push the graft as much as anterior as possible, because we don't want our cage to be in the posterior third of the interbody area. Otherwise there would be chance that it might back out and can lead to neurological symptoms. Before putting the cage, you need to ensure that you remove the patties. Now here we are protecting the L4 exiting nerve root. Now the lower patty will be removed, and with the another root retractor you will be protecting the L5 traversing nerve root for this level. The cage with the filled up bone graft will go in now. If you want, you can check a lateral X-ray at this stage to ensure that the cage has gone to the sufficient depth. It has not gone too far anterior and ruptured the anterior longitudinal ligament, which has happened sometimes. Otherwise, by just looking at how deep it is compared to the posterior vertebral body surface, you can determine how far deep more does it need to go, and if required you can punch it in a bit more. After doing this step, you need to again ensure that your nerve roots are free, because a lot of bone graft can be left behind, or while doing this procedure you might push some tissue against the nerve roots, and which can be a source of persistent or new symptoms to the patient in the post-operative period. Similar to the procedure which we saw on the other side, here also screw insertion will be done using the bony anatomical landmark. You nibble off the entry point of L4 pedicle screw just lateral to the facet joint in the midpoint of the transfer process. You use your starters to create the hole. The same starter will be used to create a hole for the L5 screw also. The one who has done a lot of open surgeries, they know the angles which are required to put in the instrument at, to ensure that they are in good position. Otherwise, at this stage you can again check on a lateral shoot of the C-arm that your instruments are going in the correct direction. One of the main aim of this surgery we do compared to percutaneous screw is to reduce the amount of radiation, and nowadays we are able to do this surgery for about 5 to 6 total C-arm shoots. So that is our primary aim of doing the surgery in this fashion, taking advantage of all the minimally invasive principle, however at the same time minimizing the cost, because we are using the regular screws, and minimizing the radiation not only to the surgeon but also to the patient. You check for the screw tracks, you ensure that they are in the good position, they have the bone all around, there is no breach, and then you pass the screws as you did on the other side. Lanky probe goes into the L4 entry point. We are on the right side of the patient now, putting the screws on the right side. Once the lanky probe goes in, while removing the lanky probe, you take it out by rotating so that you create some space for our pedicle sound to go in. Otherwise, if you put it in and remove it in a parallel fashion, then you will not be creating enough space for our pedicle probe to go in. Steps remain same. After the lanky probe, you tap, you feel again, and then you pass your pedicle screw. Little bit tweaking of the position of these retractor blades might be required sometimes to create enough working space inside, and for that you can loosen the rigid arm, especially at the joint which is near to the retractor. You align the tulips of the pedicle screw head, then you pass your rod of most of the time for the single level we are able to get away with a 40mm length rod. Now on this side we will be tightening one innie, and against this tight innie we will be compressing the other screw to ensure that our case is snugly fit inside the interbody area, and to reduce the chances of cage backing out. So we have kept the upper innie loose, but the L5 innie we have tightened. We are doing the final tightening of the L5 innie. Now this instrument goes against the tulip of the screw on which we have tightened the innie already. So it will go against, then the slot which is given in the instrument will accommodate the counter torque, and then with the lever arm mechanism which you will see just now, you bring the ends proximal to your closure. So what it will do, it will compress the L4 screw against the L5 screw, as we are seeing just now. This is what we got the compression, and after getting the compression you tighten the L4 innie also. Now usually we do this procedure on the side which is more symptomatic, and then we go on the other side and we put the screws and do the facet fusion also. But because this case was a case of lytic listhesis, so we cannot do the facetal fusion on the contralateral side. So but at the same time we would wanted to remove as much bone graft possible from the other side, so we remove the bone graft. We use that for the interbody grafting on the ipsilateral side, but we had kept the innies loose on the other side. So at this stage we will go back in on contralateral side and will tighten the innies with the help of final innie tightening tool. You do not have to put the entire retractor back in. You can use thin, long right angle retractors to pass your counter torque on the screw tulip head, and can utilize the final innie tightening tool. So this is how mini open TLIF works. Thank you very much.